Hello. We're going to talk briefly about nerve blocks and how to best do them. This is going to be part of a series where it'll start by simply discussing the basics of any nerve block, and then we'll dive into some specifics for each anatomical consideration. So first and foremost, I promise this is the last piece of histology you'll see in this lecture at least, is this is what a nerve looks like on ultrasound. It's described as a bundle of grapes. It's usually got our hyperechoic line around it. That's typically the epineurium itself. Your endoneurium ends up being the smaller hyperechoic lines within it. And then the perineurium is the dark space between them. It is generally a very good idea for you to avoid actually hitting the nerve. The best way to make a nerve block happen is to bring a needle and put it right next to the nerve and allow the anesthetic to bathe the nerve. So a fully set up kit looks like this, where you can have a whole bunch of things put together and tucked away. You most definitely need something to clean with, alcohol swabs or chlorhexidine. You need some extension tubing if you're using a two-hander technique. And then you have some sort of dressing if you're leaving something in there, or just a plain old Band-Aid would work just fine. The other way of doing it, if you don't have all those supplies, is you can simply use spinal needles because they're long enough and they are visible on the ultrasound pretty well. And you can use extension tubing, 3 or 4 of them if you wanted to use a 2-person technique. Now there's 2 styles for doing this. There's 1- and 2-person techniques. If you're using a simple block like in the forearm, which only needs about 5 cc's of fluid, you can keep the syringe on the needle and try to sort of reach over and squeeze the syringe as you go. I have found generally that it's a lot easier just to have a second person in the room pushing the meds when you ask for them, and that can help you with echolocation as well, which we'll talk about more in a second. So this is what your 2-person technique looks like. So you have the block needle, you have your IV tubing, and then you have a flush with, which typically I'll start with a flush until I get down to the area I want to go, and then I'll switch it out for local anesthetic. Now, the operator who's doing the procedure will hold the probe in their non-dominant hand, the needle in the dominant hand, and then you'll do the procedure in long axis typically. And you can ask someone to give you small aliquots of fluid as you go. Typically, you can use lidocaine or bupivacaine. There has been some recent discussion about how potentially bupivacaine might be a little less safe. I think the data on that is a little unfounded, but it's completely reasonable to just use lidocaine for most things we do in the emergency department. Just as a reminder, the toxic dose of lidocaine is 5 to 7 mg per kg, and your toxic dose of bupivacaine is 2.5 to 3 milligrams per kilogram. You want to use a high-frequency linear probe because that'll make your life a heck of a lot easier to visualize everything. You want to appropriately use a probe cover. Now, speaking of that as well, a sterile probe cover is probably the way to go. I would use sterile gloves as well. It's not a sterile procedure though, and whenever we've done it with anesthesia, they do it as a clean procedure, but not a true sterile procedure. We typically will go one step beyond that and make it a pseudo-sterile procedure by using sterile gloves, sterile probe cover, and then prepping the skin really well. And then finally we'll talk about approach. So there's 2 approaches to doing anything ultrasound guided. You have short axis where you see just the needle tip and you're perpendicular to the probe. And then there's long axis where you run parallel to the probe and you see the entire needle the whole time. I recommend doing this in long axis if at all possible. And finally we're just going to talk briefly about what it actually looks like when you do a procedure. So there you see an artery. And here is the vein right next to it. Now you'll start to see needle coming in on screen right. You'll see that the person's advancing slowly, going over the vein right there, and now it's aiming for this nerve bundle right here in the middle of the screen. You can see how they're able to see the needle the entire time. They get right underneath the nerve itself, and now they're going to inject a tiny quantity of liquid to see if it separates out. And now you can see they've pulled back a little bit. They're injecting some of that fluid. It's starting to spread around the area, around the nerve itself. You can see that the needle goes right underneath the nerve. They're going to withdraw the needle. Good, and they're still injecting a little more. Now they're going to flatten the angle and slide across. And there you see the angle is flattened. They're now moving on top of the nerve itself and injecting some more local anesthetic. And that's spreading out so that you have an almost 360-degree spread. And now they've emptied their syringe, so they're pulling out. Usually in about 2 to 4 minutes, a patient will have pretty significant analgesia. One of the resources I do recommend, by the way, is using Nysora. It's a very well put together and well researched website that I recommend. And reading and looking through. Before I do any blocks, I usually will go back and look it over one more time, even though I do these relatively frequently. Thanks for listening. If you have any questions, you know how to get a hold of me.